in the September 2nd issue of JACC. Recent studies have shown that Lp(a) is the topic, and it's a causal risk factor for cardiovascular disease. We know that, but whether Lp(a) modifies clinical risk assessment, that really is not so well established. So we're talking about discrimination and net reclassification of cardiovascular risk with lipoprotein(a). It's a prospective 15-year outcome study. It's the Bruneck study, and I am with Dr. Sam Tsamakis, who is vascular medicine program at the University of California, San Diego. And I guess before we talk about the paper proper, we really should focus, why Lp(a)? I thought we were well beyond that, but apparently not.
We're not beyond Lp(a). In fact, we're now at a reemergence of Lp(a), both in terms of the biology and particularly the clinical risk. And Lp(a) is a very common abnormality in patients. If you look at the Lp(a) levels across populations, what's considered atherogenic is 30 milligrams per deciliter or higher.
Right.
And if you look at the European data, 20% of the population in Europe has levels over 50 milligrams per deciliter. If you extrapolate that to the US and to Europe together, that's about 160 million people combined that have elevated Lp(a) levels. If you now extrapolate this globally, and with some caveats about racial differences and some other things in terms of Lp prevalence, it's 1.5 billion people that have what we consider atherogenic Lp(a) levels. So there's a lot of people out there that have high Lp(a), and there's no therapy for it, and even the recommendations that went to measure it are not defined yet. But what's clearly known is that it's a causal, independent genetic risk factor that hasn't been addressed in terms of risk and in terms of therapy.
Now, you've got 15 years of data here. What is the Bruneck study?
Yeah. Bruneck is a city in the Tyrol area of northern Italy, so just below Austria. And it's a very small area. It has one hospital. And because of that, the collaborators that I work with, primarily Stefan Kiekel and Peter Willett, who's the first author, have organized a small Framingham type study in Bruneck. They studied this in 1990 and now have more than actually 15 years of follow-up. And what they did is they took 1,000 patients, half men, half women, ages 40 to 79 in 1990. And so basically 250 patients in each group. And they followed every single patient they have data on for the complete follow-up. So not one patient was lost to follow-up. So they've done cardiovascular phenotyping, carotid intramural thickness, and a whole variety of biomarkers. And then they followed them for cardiovascular events over that time. So we had the opportunity to measure Lp(a) 15 years ago, and then we basically have tracked these patients over time and now have looked at the relationship of Lp(a) to cardiovascular risk assessment. So what we found is the following, that if you take a patient and you see them in your office, you have several risk scores that you can use to risk stratify them, particularly those that are intermediate risk.
Right.
So people at high risk, we already know, okay, you're going to do whatever you can to treat them. People that are very low risk, you probably don't need to do anything, but there's a very large segment of the population that's intermediate risk. And the question is, what do you do with them? So when they come to your office, you do Framingham risk score, let's say, which is age, sex, total cholesterol, HDL cholesterol, hypertension, smoking. You measure those, you put it in a computer, you find out what their risk is. You could also add create a Reynolds risk score, which is basically Framingham, and then you add to that C-reactive protein and family history. Okay, and that's in some studies a little bit better than adding Framingham because you have some additional inflammatory and family history, which summarizes, say, the unmeasured genetic variables. So if you look at those variables and you do risk assessment, you get your risk. So usually it's defined as less than 10%, 10 to 20%, greater than 20%. So what we did here is the newer guidelines divide risk into smaller categories. So we used less than 7.5%, 7.5 to 15, 15 to 30, and greater than 30. So we spread it out a little bit more and made it a little more relevant to current risk models. And basically what the study showed in a nutshell is if you take your clinical variables that I mentioned and you do a risk score, and then you say, okay, if I add Lp(a) to the model, to both those models, what do I get? And what you end up getting is that you can reclassify approximately 40% of patients that are in the intermediate risk category by knowing the Lp(a). So approximately half go into a high risk category, and the other half go to a lower risk category. So if you're sitting in your office and you say, okay, you're a patient from the general community, you're not a patient that has CAD yet, and I see here that you're in the intermediate risk and I'm not sure what to do. Should I treat you more aggressively? Should I treat you less aggressively? If I add LPA to the risk score, I can bump up some patients to high risk, which I will definitely treat, and I'll bump a same percentage of patients to a lower risk. I'll say, well, I can wait and not treat you right now and wait for a little bit, to see what happens to you over time.
So there has been tremendous debate as to whether we pay any attention to Lp(a), whether we actually go and get the test for it.
Yeah.
You're saying now that this data certainly starts to offer some support for get that number.
Absolutely. So up to this point, the recommendations from Europe and American societies have been that LPA can be measured in selected populations. So intermediate to high risk patients, or people that have had a family history of cardiovascular disease, or known elevated LPA in the family, or people that don't respond to statins very well, sometimes have very high LPA, and the reason they don't respond is because the statins don't affect LPA, in fact they tend to increase it a little bit. Or patients that have, say, familial hypercholesterolemia that tend to have high LPA levels and are at risk. So we've taken that whole model and moved it now to the general community, where instead of taking high-risk patients or people with established CAD that don't do well, to say, okay, here's people, just any doctor's office are showing up, can you use LPA to do that? And this is the first study that actually shows this in a general community model where we can reclassify a large number of patients, 4 out of 10, based on measuring LPA. So, and with the prospective follow-up and lack of, and the 100% complete follow-up, it really makes a strong argument that, you can measure LPA in pretty much everybody once, right, because the levels are genetically determined, and then use that. So if you find a patient has a very low level, you never have to check it again. Same thing if you find a high level, you don't have to check it again unless therapies come along, which we can talk about, because there are some emerging ones that may actually affect the risk if we lower LPA, which is something that needs to be tested.
So yeah, let's move into the treatment aspect of it. I mean, as a writer and editor for ACC for years now, Lp(a) had a real bump in terms of a great interest, and then it kind of disappeared. Yeah. Now you're saying that it could be coming back, and possibly because of therapeutics.
That's right. So besides the study I mentioned in terms of risk, there are other studies that have shown that LPA is a genetic risk factor from this perspective. There are 3 major data sets. One is epidemiological studies. So over the last 40 years, since LPA has been around, 50 years, there's been a large number of studies at the epidemiology and meta-analysis level that clearly show that it's an independent risk factor. Along with that, what really has revolutionized LPA recently is the Mendelian randomization studies and the genetic association studies, which have actually now linked the plasma levels of LPA to the genetic etiology. So if you have small number of Kringle repeats, or you have 2 SNPs in the LPA gene that are associated with high LPA levels, they drive your LPA level to be elevated, and that LPA level that's then elevated drives the risk of cardiovascular disease. So now we have genetic causality by these studies that supplement the epidemiology. What we don't have yet, and it's never been done, is a randomized trial that's taking patients with high LPA and randomized to them treatment. That's never been done. All the studies that look at niacin or other effects of LPA have been done in patients that just have garden variety LPA levels that just happen to have them in the trial. And most of those studies have very low levels of LPA. So they've never adequately tested the LPA hypothesis, meaning that there's never been a study where you have high LPA and then randomized to a therapy. Like, for example, nobody's ever done a study with niacin where people have, say, LPA levels of 75 and randomized to niacin versus placebo to see what the outcome is. We know from AIM-HIGH and we know from HPS2 Thrive that niacin doesn't help patients with CAD. Correct. We don't know if they were recruited to have high LPA, whether that would have helped them or not. So niacin is the only therapeutic agent we really have right now to lower LPA, about 20–30%. But what's coming down the road is 3 things. One, we have PCSK9 inhibitors, and depending on the study, they can lower LPA between 15, sometimes up to 30 or 40%. And then we have CETP inhibitors that also can lower LPA 20 to 30%. So those 2, if ultimately approved, could potentially be used in people that have lipid abnormalities, low HDL, high LDL plus high LPA. The other exciting thing is antisense therapy to LPA. And this is basically RNA therapeutics, where instead of inhibiting the function of a protein or activating it, you inhibit the gene for making the protein. So you inhibit the RNA with an antisense to the key site, and then you can't make protein. So I just presented the data yesterday from a phase 1 trial with ISIS Pharmaceuticals, who I work with and work at now. And what we've shown is that this is a phase 1 study in normal volunteers, but despite that, we were able to get lots of data on the effect of this drug on LPA, and we were able to get 78% reduction in LPA with 300 milligrams dosed subcutaneously once a week. So if I have a patient now, if this ultimately gets approved, with 100 milligrams per deciliter of LPA, I can get it down to about 20, which would be a fantastic way to kind of test the hypothesis.
Yes, exactly.
That you can lower LPA and look at outcomes. So that's what needs to happen when this drug is finally moving along clinical development, is it's going to give us a tool to test the LPA hypothesis because it does not affect other lipoproteins. PCSK9 inhibition and CETP inhibition affect HDL, they affect triglycerides, they affect LDL, and they affect LPA. So we're never going to be able to figure out which one of those changes may lead to a clinical benefit. Antisense is very clean. It only affects LPA synthesis or ApoA synthesis, so you can't make LPA particles. And when we do a trial with this drug, we should be able to disentangle all the other lipoproteins, separate them from the equation, and really test the LPA hypothesis.
So it looks like we should be paying more attention to Lp(a), at least if nothing else in the press for
we should be paying attention to it. And the other thing I would just want to mention is that it's the major genetic risk factor for aortic stenosis, which is a very prevalent problem now as the population ages. So this is another place where a trial can be done in people that have mild aortic stenosis, and ask the question, if you lower LPA, will aortic stenosis progression be reduced?
Well, to read this particular paper in JACC, that's the September 2nd issue, and if we're going to have to start thinking a little bit more about Lp(a), this is probably the place to start. For Cardiosource World News, I'm Executive Editor Rick McGuire.